I think we got, 40 people sign up. So, well, good morning. Welcome to Cardiac Sciences Grand Rounds. Today we have a fantastic speaker, which is Dr. Martha Gulati. Dr. Gulati is the president-elect of the American Society for Preventive Cardiology. She was professor of medicine and the inaugural chief of cardiology at the University of Arizona. And she previously held the Sarah Ross Sauter Chair in Women's Cardiovascular Health and was a section director for Women's Cardiovascular Health and Preventive Cardiology at the Ohio State University until 2015. She's the author of the bestseller Saving Women's Hearts. She's the editor-in-chief of the American College of Cardiology CardioSmart Patient Education and Empowerment Initiative, and she serves as the chair of the National Chest Pain Guidelines that will be released sometime this year. Dr. Gulati is nationally and internationally well known. She has an exceptional commitment to study women and cardiac disease, and she has won a lot of awards and distinctions, including being named the Crain's Chicago Business as one of the Chicago's top 40 under 40. 2011, she received the first Credo Coalition to Reduce Racial and Ethnic Disparities in Cardiovascular Outcomes Award from the American College of Cardiology. And she has been awarded the National Red Dress Award for her efforts in raising awareness on heart disease in women and advancing research in this field. 2019, she was chosen as the most influential woman in Arizona and received the 2019 American College of Cardiology Bernardine Healy Award for her leadership and accomplishment in the field of cardiovascular disease. She's very passionate about women and heart disease and prevention of cardiovascular diseases. She's the principal investigator of the St. James Women Take Heart Project. The study is examining cardiac risk factors in women. And then she's also participated in the Women Ischemic Syndrome Evaluation, the WISE study, and previously a co-investigator of the Women's Health Initiative. She sits on numerous advisory boards, American Heart Association, American College of Cardiology, American Society for Preventive Cardiology, and several other ones. She's published in the New England Journal, has over 150 publications in many of the journals that we all aspire to publish. And she's been featured in hundreds of newspapers across the world, including the New York Times, USA Today. She's been featured in Oprah, NBC Nightly News, CBS National News, and the list goes on. So it's a real honor to have Dr. Gulati, who is a true Canadian. She went to medical school in the University of Toronto and then did her training in internal medicine and cardiology at the University of Chicago. So we're very grateful to have Dr. Gulati with us today. And Martha, please, thank you very much for joining us today.
Well, thank you for having me here today. And sorry I don't get to be there in person, but hopefully my jokes don't just, if you want to roll your eyes, I won't see it. So that's all good. But yeah, I'm going to talk today if there are sex differences in cardiovascular disease and hopefully convince you that that is the case. So let's get started. I have no disclosures. And let's start with the ancient Greeks, because even the ancient Greeks understood that there was a difference between men's health and women's health. And when they came up with a god of health, they actually assigned Hygiena to be the goddess of women's health. And we all know that symbol of medicine, which is the staff and the snake. Well, Hygiena brought the snake. So women are never very far removed from the snake. But there are many differences between men and women. How we see ourselves certainly is different. And how we communicate, I guess when men say hi, they just mean hi. When women say hi, we mean so much more than hi. But I could spend all day talking about all the differences between men and women, but I want to talk obviously about heart disease. And this is the statistics from the United States. And you could see in the early 80s, there was less women dying from heart disease than men, but then after that, it dramatically changed. And there was a noted reduction in mortality in cardiovascular disease for men, but the same was not seen for women. And it wasn't until 2001 when we started seeing declines in mortality, but at 2001, remember what happened. 2001 was the first release of the Women's Health Initiative. Overnight, the #1 prescription, which was hormone replacement therapy, finally had a study showing that it at least did not reduce the burden of heart disease and may have increased the risk of heart disease. It was also the start of the Go Red movement in the United States. And that resulted in 3 releases of guidelines specific to women, which we hope was part of the reason we saw this decline. We started adhering to guidelines better for women, and so there was this reduction. And in the last few years, there was actually less women dying than men. But what's concerning for both men and women is this uptick, where there's an increase in mortality for both men and women in the last 4 years. And it's making us wonder, because it really is the younger generation that is dying at a greater rate. There's more risk factors at a younger age. But that's the US data, and I'll share with you the Canadian data as well. But part of the problem really is that we didn't include women in many of our trials. And we really didn't, especially related to cardiovascular disease. That was a big issue that we did enrolled women, if we enrolled them at all. And Dr. Nanette Wanger said this quote, that the medical community really has viewed women's health with a bikini approach, looking essentially at the breasts and the reproductive system, and almost ignoring the rest of a woman as part of women's health. She said that in the late 80s. And I wrote an editorial in 2019, still asking the same question, because we still haven't moved the needle enough. How do we move beyond the bikini to protect a woman's heart? I'll show you some of the data that shows, where we're still lagging specifically in cardiovascular disease. So here's the data for the United States, and I'm going to show you the data for Canada. From the 1.3 million deaths in the United States, over 400,000 of them are due to cardiovascular disease, making it the leading killer of women. Chronic lung disease is the 3rd leading cause. Lung cancer is the 4th leading cause. Breast cancer accounts for about 41,000 deaths in the United States. There's a 10-fold greater risk of dying from cardiovascular disease than there is from breast cancer, yet women really underappreciate their risk for cardiovascular disease. Again, another way to put it is just in terms of prevalence. In terms of prevalence, over 60.8 million women are living with some form of cardiovascular disease, essentially 1 in 2 women. In contrast, the prevalence of breast cancer is around 3.8 million. So again, not to belittle breast cancer, but just to put it in perspective. And we have the same data in the United States that we have in Canada. Here's the data for cardiovascular disease accounting for 32,000 deaths in Canada as of 2017. And breast cancer accounts for about 5,000 deaths in Canada. So again, it makes cardiovascular disease the leading cause of death for women in Canada as well, kills 7 times more women than breast cancer. And again, we find the same trends that I'll show you in the United States, that when a woman has a myocardial infarction, they are more likely to die compared with men. And we see this in all Western world countries, that pretty much that this is the same trend. Now, like I said, part of the problem is we've really under-enrolled women in most of our trials. And, I love this cartoon because it's funny, but it's also very true for cardiovascular disease. We have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition. But medical research using women as subjects just never occurred to anybody. And that is very true for cardiovascular disease. You can see this paper that was published in JACC in 2018, when they corrected for prevalence of the disease. They found that there is areas that we've made better, we've included women in a better way. Atrial fibrillation, hypertension, and specifically pulmonary hypertension, where we have enrolled women in a good way. But common things being common, acute coronary syndrome, coronary artery syndrome, heart failure, these studies, we have not enrolled enough women still to this date, which is a major problem given that these diseases are so prevalent. There's another study that was published last year that looked at this all over the world. And they found the same thing. We've enrolled enough women in pulmonary hypertension. It is a female predominant disease, but all other conditions, but particularly heart failure and coronary artery disease, we've under-enrolled women. It doesn't matter if it's a drug, device, lifestyle, if it's a procedure. It doesn't matter where the study was done. Globally, we are terrible at enrolling women. It doesn't matter the size of our study. It really doesn't matter the age of our study, although we're getting better, obviously, at enrolling under the age of 55 women. But since these diseases often affect women in older ages, we aren't so good at enrolling women. And sponsor type really doesn't matter, although you can see that governments sponsored trials seem to do the worst about enrolling women. So again, we always need to look at our trials and keep being critiquing them. Are we enrolling enough women? Now, why does it matter to have women? I mean, women are not just small men, right? I mean, if sex really matters as gender matters, and both of them are important and can't be ignored. But for biology, I mean, being XX versus XY, that ultimately means that every cell in our body has a sex. So it is influenced, everything that we do and every biochemical reaction we have in our body is influenced by sex. We need to know the sex differences, just like we need to know the gender differences. And sometimes it's hard to tease the two apart, obviously, but sometimes it is biology. All of these issues are important when we're considering the effect of cardiovascular disease, both how we treat it, the outcomes, all of this in our environment, our lifestyle, and our biology matters. So we need to take that into account. So let me lead you through where I think that there's some gaps. So the first question I would ask you is whether we even follow the guidelines equally in women compared to men. And for now, I'm going to be talking about ischemic heart disease or acute coronary syndrome specifically. So from the United States, we have this data called Get With the Guidelines data. It's voluntary across the United States, but it is some of our best hospitals who like to be public about their outcome data for acute myocardial infarction. And this is a bit older data, first from 2008, where we first looked at sex differences, the odds of a woman getting certain therapy compared to a man. So pay attention to this column. If the odds ratio is greater than 1, it means a woman was more likely to get it than men. And if it's less than 1, women were less likely to get it compared to men. And if it's equal to 1, they were equal. But you don't see any 1s or greater than 1s, really. After a myocardial infarction, women were less likely to get aspirin or beta blocker within 24 hours. They were less likely to get any type of invasive procedure. They were less likely to meet our standards of care in terms of our door to needle time or door to balloon time or any acute reperfusion therapy. The only thing women did better than men was die, and particularly the ST elevation myocardial infarction group was statistically significant. We looked at that data in 2008, but we re-looked at it in 2016, and we still found the same trends. Women were more likely to die than men, and women were more likely to have bleeding complications. And it was worse to be a woman, but it was particularly worse in the United States to be a Black woman, where there's greater disparities in care. We have the same data in Canada, and I could literally take you on a worldwide trip and show you that every Western world country that's collecting this data shows the same thing. But this is some older data from Canada. Women were less likely, again, to get the guideline recommended medical therapy compared to men. They were less likely to undergo invasive procedures. They were less, and revascularization. But again, women were more likely to die both acutely in the hospital and out at 1 year. And we have data for your province as well from Alberta that was released last year and published in Circulation. As you can see here, women shown in red and men shown in blue. Whether it's STEMI or non-STEMI, women do worse than men repeatedly. And again, when they follow this was a long-term follow-up in the province of Alberta, and they continued to see this, although the risk was less so for non-STEMI versus STEMI when they teased it out. Interestingly, I don't have the figure here, but they also showed when they included heart failure, it was significant for STEMI and non-STEMI. that there's more rehospitalization, more greater risk for women to develop heart failure as well as die in the time after myocardial infarction. So we really need to be cognizant of these differences. Now, the Virgo study, it was looking specifically at younger women who have ST elevation myocardial infarction. They defined younger as those under the age of 55. And this particular paper wanted to look at the door to balloon time based on sex. And this was in men and women, men again shown in blue, women shown in red. And if they had PCI capabilities in their hospital, they still met the under 90-minute threshold, but it was statistically significantly longer for women by about 8 minutes. But if they did not have PCI capabilities, they did not meet the 120-minute door to balloon time threshold. It was actually 30 minutes longer to treat a woman than it was to treat a man. Now, in this particular study, it didn't translate into worse outcomes, at least based on what they collected, but these were at very good hospitals. And in real life, we know that these delays really do exist and that they also are associated with the worse outcomes. I can show you so many sex differences. I'm not just trying to highlight some of these. This was a paper that just came out, I think, yesterday. This was a paper by a group that looked at the national inpatient sample, which is a publicly available database. And this was just ST elevation myocardial infarction and people who presented in acute cardiogenic shock. So the sickest of the sick patients. And they found here, again, this is from 2006 to 2015, but they found significant differences between men and women. And in terms of women were less likely to undergo invasive cardiac procedures, which included revascularization as well as mechanical circulatory support. And the highest mortality rates they saw were in women compared with men, but also based on race. Blacks and Hispanics also had poorer outcomes. So it's, again, this is a real life sample. The National Inpatient Sample is a really good database that we use often to look at what's happening. The other thing we know, and that really does matter to the healthcare systems, is the risk of rehospitalization. And we know that for women, they're more likely to be rehospitalized after myocardial infarction, but this particular study, the TRIUMPH study, looked at rehospitalization stratified by age, again, using the threshold of under 55 or those over 55. Women are shown in gray, men are shown in black. The younger people are the solid lines and the older people are the dashed lines. And you can see very early, these lines start separating, but it's particularly worse for the younger women compared to the younger men, although it's significant for both. And this is over just 12-month time after an acute myocardial infarction. So these, again, give at least health systems cause for pause, because certainly rehospitalization is not what they want. Now, there is system-based approaches that have been proven to improve outcomes. This is just one. I just like this study that was published in 2018. They had a 4-step STEMI protocol in their emergency room, and you can see it's listed here what they did. They had a standardized activation of the cath lab with the STEMI. They had a handoff list in the emergency room for all these patients. And if they didn't do PCI, they immediately transferred the patient to an available cath lab. And they also insisted that radial approach be used in all patients. And that was particularly because, as I'm sure everyone here knows, the newer data is that radial approach improves outcomes specifically for women. They have less vascular problems. So what they found, the blue lines reflect prior to this 4-step protocol, and the red bars are after the protocol was instated, and the percent of men who did better than women. And in general, men still did better after they instilled this 4-step STEMI protocol, but really the gap started closing. So it was significant. And in fact, for stroke, you can see actually women, after they started the STEMI protocol, actually for stroke, women did better than men. And that was the only measure where women did better. But these system-based approaches really can help us using things like Epic and other electronic health records where they prompt us to do certain things can actually improve outcomes and improve care and prompt users to do the right thing. So I wrote the editorial that followed that paper, and I was really trying to figure out why women do so poorly after ST elevation myocardial infarction. And I recommended that, not only do we work on increasing awareness for women, and certainly there's some issues about delays in women accessing care. But we also know that there is differences and biases about how healthcare providers approach women and how we are less aggressive with women's heart health and when they're presenting with an acute condition. I think this idea of using standardized protocols really should be implemented. I also think there's ways to use artificial intelligence that can help us adhere to care, and I'll show you a few of them as well. And I also, of course, think that we need to do more research to understand these gaps, because there's still gaps even after we instill some of these standardized protocols. Well, the other question I would pose to you is whether women even experience cardiovascular disease like men. Is that why we didn't include them in trials? Are we not appreciating their differences? And there's this term used in cardiology called Yentl syndrome. And this was coined by Dr. Bernadine Healy, who was the first woman to head up the National Institute of Health and a personal mentor and hero of mine until she died a few years ago. But Bernadine Healy, she termed this coin because from the book, which was also a movie starring Barbara Streisand, and just so that you know, Yentl wanted to study the Talmud, but as a woman, she could not. So she had to disguise herself as a man to be taken seriously and to be able to do what she wanted to do. So she used the story really to say, what is it about women that we're not including them in trials? And when she headed up the NIH, that was a big push for her to get women enrolled in trials. If they wanted NIH money, they had to enroll women. But her point was that the assumption was that women have to present exactly like men, then maybe we're going to miss men. Ultimately, this got translated a little bit wrong, I think, in our cardiology community, because also people started thinking women present so differently than men in terms of angina symptoms. But I'm going to show you some data that shows that that is not true. From that Virgo study that I already talked about, that study of young men and young women with myocardial infarction, they looked at this very question because we really didn't know much about young men and women and their presenting symptoms. And so for those people that were under the age of 55, and they all were diagnosed with a myocardial infarction ultimately. So what they found is that 90% of men and women presented with these classic symptoms: chest pain, chest pressure, chest tightness, or chest discomfort. The difference between men and women was really that women were more likely to present with 3 or more other additional symptoms in contrast with men. It's also that more women actually sought out care prior to their hospitalization for the myocardial infarction, but women were more likely to be told this wasn't heart related. And again, these were people that all went on to have a myocardial infarction. Just to look at the data very quickly, you can see men often thought that their symptoms were muscle pain. Women were convinced that it was more likely stress and anxiety. The reason that they actually sought out medical care was related to whether they were worried about heart problems. That was more likely that for men. Women were more likely to be worried about other health problems. But for women, it ultimately meant that there was a greater delay in care. They were more likely to present after 6 hours. So again, these are things that are, issues as well. But for those who sought out medical care prior to their hospitalization for the myocardial infarction, and in fact, more women sought out care than men, many of the healthcare providers did not think it was heart related for the women, in contrast with the men. So there is bias in healthcare workers as well in terms of how we approach them. Now, the AirMay studies also wanted to look at this, and what they did was really something very smart using artificial intelligence. They used cardiolinguistics technology to listen into the conversation for the patients describing their symptoms. And they also found around 90% of women and men presented with a very typical symptoms, as you can see here. And it wasn't that these other more atypical symptoms weren't present, but they were also present in men. And if they went on to have obstructive coronary disease, they were more likely to have these typical symptoms. So I think that's just so important to appreciate that. And again, this machine learning can really help us. And I think that we need to really, though, also abandon this idea of atypical chest pain. The biggest reason being is that when I have fellows approach me and say this person has atypical chest pain, what they mean is not that it's a less typical way of presenting. Rather, they mean this is not angina, and I don't think that we need to do anything. So the definition of atypical has also been a little bit messed up. And yes, our chest pain guidelines will be coming out, and you'll see we focus heavily on that. Again, another study from the high stakes group in the UK, they looked at this as well. And in terms of people who went on to have a myocardial infarction, they also saw that it was more likely actually for women to have the typical symptoms: pain in the chest, arm, jaw, dullness, heaviness, tightness, pressure, ache, squeezing, crushing, or gripping pain was much more common in those people who went on to have a myocardial infarction. It was true also in this study that women were more likely to have additional symptoms, but the typical symptoms were there. So the question really is are we not listening to women, or are we not asking our questions in the right way? But they are saying these symptoms when we are actually looking for them. The next question I would pose to you, though, is whether the guidelines even apply appropriately to women. And not that you have to read all the details in our guidelines for stable ischemic heart disease here, but my only point is that this guidelines, which was just slightly updated in 2014, but really this figure didn't change. All they said is that what they were looking for is who should go to the cath lab. So how do we use stress testing? Who needs to go to the cath lab? With this overt focus on obstructive coronary disease. And when I was in medical school, I learned this too. I learned that only when you had an obstructive artery could you have symptoms, could you have an abnormal stress test. It took this obstructive plaque. And I really think that has been our focus for so long. And these are actually very wrong. But that has been our idea, that the pathophysiology for ischemic heart disease required an obstructive lesion. And we know, obviously, that is not true. I know that University of Calgary does a lot of work in this area as well. So I think I don't have to convince you a lot of this. Some of the early data we did, this is a study where we used a normal cohort known as the Women Take Heart Project, which is my baby. And then we compared it to the WISE study, the Women Ischemic Syndrome Evaluation Group. And we showed that those people who had signs and symptoms of ischemia, which was the WISE study, whether they had clean coronary arteries, which was the group 2, or 1 to 49% stenosis, which is non-obstructive, they went, by having evidence of ischemia over time, they went on and had more major adverse cardiovascular events compared to an asymptomatic cohort of women that were age and race matched to the WISE study. So, but other studies now have shown this, that it's certainly not as bad as obstructive coronary disease, but it certainly is getting close. It's like having single vessel disease, and the repeat hospitalizations are very costly to the healthcare system. We know this disease, the obstructive pattern. Obviously, we know more of what to do with it. The idea of what's going on, if it's the microcirculation, is less known. And we now have proper terms for them, ANOCA and MANOCA, but I would still argue that these terms, ischemic with no obstructive coronary arteries or myocardial infarction with no obstructive coronary arteries, are more buckets. And we will probably be teasing out these differences for a while to understand, one, how can we identify the different things that could cause this? but also the unique treatments that might exist for these as well. But again, these are much more common in women than they are in men. And there's so much more we need to learn. I think that this paper that came out last year was really good. It's all a lot of information, but there's so many differences between men and women in terms of triggers, in terms of characteristics of the lesions, and in terms of our differential diagnosis that we need to consider for women compared to men. And for obviously the different diseases that affect women more often, things like SCAD, things like vasospasm, things like Takotsubo's, not that they can't occur in men, but certainly we see them more frequently in women. So we have a lot of work still to do. In terms of ischemic heart disease, the way to think of it is that there's a difference in risk factors. Even the way traditional risk factors affect women, many of them are stronger predictors for women. So if they're present, things like diabetes, hypertension, even obesity are stronger predictors. Even chronic kidney disease specifically is more common in women who have ST elevation myocardial infarction. There's female specific risk factors that I'm going to get into, and female predominant risk factors, things like lupus and rheumatoid arthritis and breast cancer. There's differences in presentations and like SCAD and less plaque burden, as we already talked about. There's differences in access to care, like the delays we already talked about, but also the differences in treatment as well. Women are less likely to get the guideline-directed medical therapy. And ultimately, these account for the differences that we see in outcomes where women have the worst, both short-term and long-term prognosis. So we could look at this for many different disease states, though I don't have enough time to talk to you about every disease state. So I'm just going to highlight a few things. Heart failure, there's differences, not differences in our lifetime risk or the fact that it increases in age, because that's true for men as well. But heart failure with preserved ejection fraction is 2 times more common in women compared to men. And heart failure with reduced ejection fraction is twice as likely in men. And we need to do a better job at really understanding these sex differences. If I could talk about TAVR, again, I know that's an entire talk of itself, but there are differences. And actually, this is a really positive area that women actually do very well with TAVR and maybe better than men. Some of the data supports that. And women are definitely higher risk in all the TAVR trials. They had a higher risk than men. So, and then in real life practice, we've seen it as well, that women are higher risk, but they do at least as well as men. So, we need to really identify if they could probably do even better if we identified them earlier to decrease their morbidity and mortality. We know that they do better with TAVR than they do with SAVR. So, we should be offering that up front. And I think we are doing more of that these days. But certainly the biggest barriers are both access and referral biases, which we need to really close those gaps. I could talk about cardiac arrest. And again, there isn't enough time for me to talk about every part of cardiology. So I'm just highlighting a few things. But, even this is interesting in the community that when women have a cardiac arrest, that even a bystander won't initiate CPR as likely as they are to do it for a man. And we've asked, we know that it's life-saving. If we do it sooner, we have more lives we can save, but we do less for women. Well, why is that? Well, my biggest reason I'd say is we don't teach CPR properly to our community. They are often afraid to touch a woman's chest. They think they will hurt her, or that they think that touching a woman there might be inappropriate. But our Annie dolls don't look anything like women. So maybe instead of mannequins, we need to start finding womikins and start teaching people on anatomically correct so that we can save lives, because of the fact that women are more likely to die if they sustain a cardiac arrest. Stroke as well. Again, not enough time to talk about every state, but stroke, especially in young women, is devastating. And a lot of them are related to pregnancy, particularly after pregnancy, but 1 in 5 strokes in women under the age of 35 are related in some way or form to pregnancy. And I know you guys have a great section that already looks at a lot of this, but again, the different risk factors for women we need to understand. In terms of the outcomes, we know that it's very poor if you have a stroke after pregnancy, particularly. Most of them do occur postpartum. And we know hypertensive disorders of pregnancy are the leading cause of both ischemic strokes as well as hemorrhagic strokes. But for other women not related to pregnancy, we even know that there's risks related to contraceptives that we haven't fully appreciated. There's obviously some hypercoagulability associated with the people that have strokes, or also smoking history as well. But we also can't underestimate the things that are used so frequently in our female population, and these are young women, and we need to understand more about them so that we can at least assess those people that might be at a greater risk. So I think there's a lot we still have to learn, but these are often biological differences, as I started with saying that, you know, biology matters, and the XX for women ultimately dictates how, you know, what hormones we release into our system, but also our biochemical makeup and how our organs will respond to all of these things. And it's not just the cardiovascular system, although that's what I know, but I think every organ in the body, we need to do a better job at understanding sex differences. And I know that already you guys have someone leading this, and I very familiar with the work that is being done in this space around sex differences at University of Calgary. So I won't lecture on that any longer. But I'm a preventive cardiologist, though, so I'm going to spend the last bit of talking about risk factor differences, because that's really what I like to do, is identify women at risk. I call myself an early interventionalist because I try to keep them away from needing any of the interventional folks. But do the risk factors even affect women the same? And you can look at the traditional risk factors that we know, certainly in terms of prevalence, that there's less women smoking than men, but the relative risk to the heart is greater. Same for diabetes, although diabetes is greater in women, but its relative risk, if you're a diabetic woman, is greater than if you are a diabetic man. Hypertension as well. I know it's a lecture unto itself how it affects women compared to men. Fitness and physical inactivity at every age group. Women do less physical activity or are less fit compared to men. But the risk may be greater being poorly fit in women compared with men. There's these female predominant conditions, things like lupus and rheumatoid arthritis, these inflammatory diseases that are 90% more likely in women than in men. But as of yet, we don't know of any sex difference in terms of their cardiovascular effect, but these are diseases that we are much more prevalent in women. Same with depression and mental stress, that we know there's a connection to the cardiovascular system. Also uniquely for women, there's things that are sex specific, right? Things that can happen during pregnancy only related to diabetes, like gestational diabetes or hypertension.
Do you have some time when you're done? Do you want to pop by for
hypertension during pregnancy. Sorry, somebody's.
Oh, okay. Yeah, actually,
Sorry, can you guys please mute Tara?
No. I just mean that I'm not on the speak, so you can talk right now if you want.
Tara, please mute.
Sorry, and then
Those of Zoom.
Yes. Obesity as well. The weight gain during pregnancy can increase the risk of cardiovascular events. And then there's things that are just specific to women, things that our reproductive system dictates, things like polycystic ovarian syndrome that we need to take into account. So sorry, I kind of lost it there for a little while, but in terms of our ASCVD risk score that we use frequently in the United States, it has the traditional risk factors that come into play. And as of 2018, we added in the idea that you should also use risk enhancers to further refine this risk score, because there's really nothing in this risk score aside from pressing whether they're male or female, and that there's other things that you need to take into consideration. And a lot of them are sex specific. So let me just end with, like, what are the things we should be assessing when we're trying to prevent cardiovascular disease, or when we're trying to identify a woman that's at higher risk? Well, I think the most important thing is related to pregnancy, the pregnancy complications that can occur. Effectively, that is, pregnancy is like a stress test. And it identifies women who would benefit from primary prevention efforts to reduce the risk of atherosclerotic cardiovascular disease. These adverse pregnancy outcomes, I would say, just focus on the top 4, because that's what the data we have the strongest on: preterm delivery, gestational diabetes, hypertension during pregnancy, and that could be gestational hypertension, preeclampsia or eclampsia, and fetal growth restriction. So being in the lowest 10th percentile, a small for gestational age is another term that's used for that. Macrosomia is often related to gestational diabetes or maternal diabetes, and parity has such a strong association with socioeconomic status that they have not sat as independent predictors for cardiovascular disease. But we know that 80% or more of women bear at least one child, and about a third of them will report an adverse pregnancy outcome. So it's important for us to be asking these questions. Let me just show you quickly some of the data related to that. This is from the Northern Finland cohort, where they followed all pregnancies from 1966. This was all women who gave birth at 1966, and any form of hypertension predicted not just future risk of hypertension, but future risk for cardiovascular disease, diabetes, and chronic kidney disease. So that was one of the first hints that this was important. And we've had multiple other population studies come out and show this. I just like this one study from the UK, the Caliber study, which was the entire population of the UK of 1.3 million UK women, more than one pregnancy associated with preeclampsia or any form of hypertension. Not only were they seeing greater ischemic cardiovascular events, but other things as well: heart failure, atrial fibrillation, were also associated with hypertension during pregnancy. This elegant study from France was showing an association between gestational diabetes and cardiovascular disease. And they took all deliveries between 2007 and 2008 in France and looked at those who had gestational diabetes compared to those who didn't. And you can see that just after 7 years, there's a greater incidence of myocardial infarction and stroke and angina. Again, just after 7 years. These are still very young women because they had just delivered a baby. So we know the average age is quite young for this, and we can't underestimate. These are the early cardiovascular events, not the people that we're waiting for in their 70s or 80s, but the young women that are dying from heart attacks. Some of the work that we did was related to preterm births, and this was with my friend and colleague, Dr. Mamas and Dr. Pensy Wu. We looked at preterm birth and showed a strong association of delivering before 37 weeks between cardiovascular events, but both heart disease and stroke. And when you further refined it to less than 32 weeks at the time of delivery, these relationships were even stronger. Women remember everything about their pregnancies, actually. And so it's very easy to get this history from them and ask them these kind of questions. When did you deliver? When was the time of that? We don't know entirely the mechanisms of what's happening with all these adverse pregnancy outcomes. And I'm sure it's through many different pathways, but we're learning a lot that there's probably some people who already have risk factors ahead of time prior to their pregnancy. And certainly that puts them at risk, but there can also be things that are activated during pregnancy. And there might be signs of vascular abnormalities related to placental dysfunction that may be the reason that things are occurring. We still have a lot of work we need to do, but this is ultimately what we need to do, is identify them early and try to start our preventive strategies early. And I know that already you guys have experts doing this every day. And so I think this is great, because this is the only way we're going to change the trajectory specifically for young women. There's other things about women that you need to know as well that increase their risk for cardiovascular disease. Obviously, age of menopause, even when it's natural, the earlier it is, the greater the risk is for cardiovascular disease. So I always ask that, not just if they're postmenopausal, but when did it happen? The age of first birth also matters. Earlier age, greater risk of cardiovascular events. So the way that we wrote this article and just summarized this for people, but that, depending on who you're attacking for prevention, if they're younger women, you want to be asking specific questions related to that. If you're identifying people during the reproductive years, all the adverse pregnancy outcomes that we were talking about, but also premature ovarian insufficiency and premature menopause matters as well. For older women, when you're talking to them about prevention, certainly knowing their menopausal history, hormone replacement therapy use, all matters. So I think that, it's across the lifespan, and we need to start approaching women and talking to women about heart disease in the same way that we talk about other conditions and screen for them and proactively try to prevent other things. We'd have to do the same for cardiovascular disease. Also, it's important to appreciate the relationship between breast cancer and heart disease. I think all of us know that many of the traditional risk factors are strongly associated both with heart disease and with breast cancer. And there's this idea that we blame patients for heart disease and not breast cancer. And yet we shouldn't be blaming anyone. When you have these risk factors, you're at higher risk. There's also some risk factors we can't change, but they're associated with even the BCRA genes that are identified with breast cancer have now also been associated with heart disease. So it's an interesting relationship. But for those people who get diagnosed with breast cancer, depending on what their therapy is, if they get chemotherapy or radiation therapy, it accelerates the risk for cardiovascular disease. And in fact, women are more likely to survive their diagnosis of breast cancer, but much more likely to die from cardiovascular disease. And so we need to be proactive in terms of our cardio-oncology treatment for this group, is to be connecting them and assessing them for their future cardiovascular risk. So my point is that we just, when you think about the heart, when you think about breast, you have to also think about the heart for this patient population. We know that it's the chemotherapy, the anthracyclines, the Herceptin. Again, these are life-saving drugs, but there's an increased risk for heart disease, and the combination of both of them increase the risk even further. And then radiation therapy accelerates the risk for cardiovascular disease, as was elegantly shown in this older study from the New England Journal of Medicine, that showed that for every gray of radiation a woman received for breast cancer, they increased the risk of cardiac events by about 7%. And if you had more cardiac risk factors, the risk was greater. So on average in the United States and Canada, we give about 1 to 2 grays of radiation for breast cancer. I don't even try to find out what the dose is. I just ask if they got radiation therapy and be able to note that that's obviously another additional risk factor. So my approach to women is this. I use the ASCVD risk score when I'm working on prevention. And of course, including family history, those high risk groups like veteran women as well in the United States, that's considered a risk factor. South Asian women as well is a risk factor. Then we identify sex-specific risk factors, like all the things I just got to talk to you about, the female predominant conditions like lupus and rheumatoid arthritis, and I don't have that's a talk unto itself as well. But I think that that's the way that we personalize it for the patient. We don't need genetics at this point to do a good job at preventing heart disease. I think it's identifying people at risk, which we aren't, if we're not doing it with a sex-based approach, then we're probably not doing it right. So I hope that I've had the chance to convince you that there is sex differences. And the biggest thing is that after a woman has a myocardial infarction, they do the worst. If the only thing that we could do is make sure that women adhere or receive guideline indicated therapies, we would save more lives of women. It's important to note that the younger women are at the greatest risk for poor outcomes, and this is a group that needs more attention for us to further understand why. Are they not going to cardiac rehab? Are they not getting the follow-up care that they need? Are we not being aggressive at the forefront? There's a lot of different questions about younger women. I hope also I've convinced you that the symptoms for angina are actually typical in women, and we really need to move away from this nomenclature of atypical. I'd just rather us not use it because it really isn't giving the right message. I think also there's sex-specific risk factors that we need to take into account and be better at preventing heart disease. We all need to be early interventionalists. And I think lastly, if I could leave you with my final point, is women need to be studied. There's sex differences, but we have to look for them. So the last word is really my husband. This is supposed to be him on Halloween. Apparently he said he was still waiting for her to be ready. And as I always tell him, there's just so much more to understanding women. So again, thank you for having me here today. And I don't even know the time. So if there is time, I am happy to take questions.
Thanks, Martha. That was fantastic. Yeah, we got plenty of time. So let me ask you first, like a question on more on the public health view of this. So you raised the issues about how breast cancer has been so successful. So why haven't we adopted some of the breast cancer policies and strategies into women and cardiovascular disease?
Yeah, that's a great question. I always say that breast cancer has the best PR team, and they really do, because they've used their, the pink ribbon is universally known worldwide. They know what everyone knows what it means. And they've been able to direct public policy in the United States more than in Canada. I would say, like, there's this big fight about when do you screen for breast cancer. A lot of it has to do with people wanting screening done early and not always based on science. But we have to do a better job. So if in the United States, we use this red dress symbol, and I think that actually is not a great way. It hasn't conveyed the message. Every day I wear that red dress symbol on my lab coat, and patients on a daily basis ask me, why are you wearing a red dress? Like, on, what does that pin mean? It means that the message actually hasn't gotten out. And I think it's time for us to reconsider it. I think Canada did a good job. I mean, Seeing Red was a great campaign, and I think that was highly effective. I think we need to invest more in our public policy to get the message out to women. And that's part of it, but it's not the end of it. We need to do a better job of educating physicians, and that starts in medical school, but it doesn't end there either. We need practicing physicians out there at the forefront to be able to understand where our biases have influenced the care of women. So I think it's time, I think, and I know that the Canadian community is actually actively working on this. There's a Canadian-wide network that is trying to figure out these, working with the Heart and Stroke Foundation in Canada. And I think it's great because they've actually got, even though they started a little bit later than the United States, they get to learn from our mistakes. And I think that there's so much room to try to do this in the right way, and putting out these public policy statements that Canada is doing is great, but I think we have to get the community behind us as well, because we need the public messaging and the sympathy. We also need to stop blaming. There seems to be a perception that heart disease particularly is blaming a patient for their lifestyle. We talk a lot about lifestyle, but so does breast cancer. How can you prevent breast cancer? A lot of the same steps are how you prevent heart disease. And if we take a more policy stand with health matters. Our health matters. We should be putting into places, make it easy for people to exercise, make it easy for people to access healthy food. That's the way to change our society as a whole. So I don't know if I exactly answered your question. It's a long.
No, it was great. Yeah, but I mean, there's plenty of room there for improvement. And a second point before I get to some, there's a lot of questions here in comments. So the other issue you brought up was the low recruitment in clinical trials. So why don't we just mandate that every clinical trial has a 2-to-1 randomization, 2 women per 1 man?
Well, even if we did a 1-to-1, it would be great. I think you have the expert there. Dr. Ahmed is like the person, I think, leading the charge about sex, the need for studying sex. And I think that the most important thing is to not create barriers when we create trials. First of all, to be cognizant, we want to get women and men into these trials. And, sometimes you do need a 2-to-1, like Virgo very intentionally, that study of younger men and younger women, they intentionally did a 2-to-1 ratio. But when you're just looking even just for a proportionate representation, we shouldn't have barriers that would somehow bias women not to enroll, whether it's the things we're asking them to do, whether it's the way we describe the study, involving patients also into our trials. When we're planning trials, and PCORI is a big example in the United States, there's patients on these study boards and they come up with the ideas. And I think it's a great way to understand, why would a woman not enroll? I'll tell you, we did this study in Chicago called the Women Take Heart study, which is my study. And in 60 days, we enrolled those 6,000 women. People said, you can't get women into a trial. We got 6,000 women in 60 days. How did we do it? We provided valet so that it was not inconvenient to the patient. We provided daycare. So while the woman was doing her stress test, because every one of those women underwent stress testing, so they had daycare there set up for them. We had hours that were ridiculous because we literally worked from 6 a.m. till I think 8:30 p.m. was when we would close up. And that made it flexible. Maybe they were waiting for their spouse to come home. Maybe they were coming home from work and that's where they could fit it in. But we did what everyone told us was impossible. So it's just something we need to think about this. And I think having patients guide us a little bit. Why would a woman not enroll? What if you have a trial and it only has a picture of a man on it? Then guess what? Women aren't going to think they're invited as well. So we just need to be a little bit more aware of what we're putting out into our community.
Great. So some questions here from Dr. Raji in Edmonton, actually. So do you implement psychological evaluation in the assessment of risk of recurrent events in women? And, there's lots of literature and you showed some data there that women have a higher prevalence of stress and depression. So do you do this routinely?
So especially after bypass surgery, we should be doing better. I don't think that anyone does it very well unless you have it implemented into your post-operative care. And we did when I was at Northwestern, we actually had that, but it was part of a study. And then it ultimately got transformed. And I think Paul was there at that time. It got transformed to be routinely used. Most places don't do it, and I can't admit where I am right now that we are doing it routinely. It's unfortunate though, because that is a way to identify the highest risk group, the people that are not going to go to cardiac rehab, the ones that are not going to follow up with you, the ones that are not going to take their medications. Because if they have significant depression and you don't address that, you're not going to do a good job in caring for those patients. So I think we need to do better. And I think it needs to be part of a standard of care rather than, yes, this works, but we don't do it, which is sort of like the cardiac rehab story too. We know it works. We just don't even prescribe it to patients. And we definitely prescribe it less in women compared to men.
So Dr. Fedak wants to know, what is the role of Women's Health Clinic for cardiovascular disease? And should every heart institute have this program? And what is the potential impact of that?
Yeah, that's a great question. And, I hope one day we don't need to have a women's heart center or women's heart clinic. But I think right now, while we've just at the infancy of understanding sex differences and understanding the difference between men and women, there's so much emerging data that you do need the experts focused on it before it's main stage where everybody understands these differences. I think that that's why, we wrote a paper about why we need women's heart centers was really based on that. As the data is emerging, we need to know more. One day it should be standard part of everybody's education. Every cardiology fellow should leave knowing both, because listen, we're special, but we're not a special population. We're 52% of the population, and we need to know how to treat the majority. But when we're seeing these gaps, that exist universally. It's not just one country does less well. It is universal in the Western world that these gaps exist. How are we going to close those gaps? And that, I think that's why we are where we are right now.
Yeah, I guess that touches on a point that Dr. Ahmed wanted to make, that, instead of talking about women's cardiovascular health as a specialty, focusing on incorporating this into all the research education, because women are 51% of the population. So I think you addressed that. And so question here, if there's no evidence-based blood pressure and lipid targets for women who have history of complicated pregnancies, what are your targets?
Yeah, that's a great question. So, when we talk about what should we do for these high-risk women, and we don't know. We need studies, and I know Dr. Nuremberg and some others in Canada have actually led in this space. So, I mean, but we do need to know what's the effect of them in terms of what should we be treating and what actually influences their outcome. So I think that's an area that we need to study. I think the blood pressure story is so interesting for women, not even just related to pregnancy, but just through their lifetime. We've never really talked about sex differences. We always thought that the time that blood pressure changed, it was elevated once you went through menopause, that it went up. And now more recent data that's come out of Cedars-Sinai has shown that actually we start out lower, as we all know, for women compared to men, but our trajectory, our rate of increase is actually higher than men. Maybe there is going to be different blood pressure thresholds for women compared to men. Maybe the 130/80 doesn't actually fit everyone, and maybe for women it should be different. And this is specific, even related to pregnancy, because we don't really know what's abnormal. Every country's kind of made up their cutoff. Here's where we're gonna treat, but every country is actually different. And I think we need more data. So that this is the exciting part, is that, we get to all be at the part of changing this and studying this and trying to come up with the answers.
Oh, great. We're at the 9 o'clock, but my last point would be that, I always feel that's an area that is not that exploited, is what are we going to do with this transgender health? Because, we are, going to be seeing a surge in cardiovascular disease in this population, and I don't think we're prepared for that.
I agree. And I think when we're talking about the disenfranchised groups, which women are just one part of, we need to be focused on all the groups that we've traditionally ignored, because that comes with fighting for equality. And this, you're absolutely right. I think this is the area where there's the biggest gaps, and that we can't let this just wait until it's a problem where we have enough people where we're like, oh, they're dying of a greater risk of heart disease. We do not know what to do for the trans men, so women that are transitioning to men. Specifically, we're seeing really high rates of cholesterol in this group because of the hormones that they're taking. And we don't know, using their younger age, they'll still come out as low risk, no matter whether you put them as biologically a woman, they're going to come out as ridiculously low risk, no matter what their cholesterol is. We need to identify which thresholds are really dangerous for this group, and what should we do, and how would we be able to modify their therapy, but also meet the demands that they want and their goals of what they want to achieve. So I think that this is again, we shouldn't leave anyone behind. If we've left women behind a long enough time, let's bring everyone with us as we try to move forward.
Well, thanks, Martha. That was fantastic. And thank you again for spending the time with us. And we hope to see you soon.
All right.